Good morning, and thank you for the opportunity to present our work today. We have no disclosures, but the disclaimer here is that I am now the third author who has agreed to present this work, so please bear with me if there's any issues. When it comes to surgical proficiency, we know that volume matters. Many studies, examples being Begg et al. And a study by Birkmeyer, have shown that higher volume hospitals portends less mortality and fewer complications. When evaluating a surgeon's experience individually, we know that higher volume or higher caseloads portends higher experience and less mortality. And further, we know that there are some unacceptably high mortality and morbidity rates in very low volume hospitals. Birkmeyer et al. Helped us define what high volume really is by looking at major oncological procedures. They found that the higher the volume, the less mortality across all of these procedures, the most dramatic of which was pancreatic resection, which found an absolute difference of 12%. This is important because most DoD facilities fall in the low to medium range for volume for most oncological procedures. This is and will continue to be an issue as national societies such as the American Cancer Society make recommendations or trend towards requiring a minimum number of cases per institution to continue to do those major oncological operations. And as many people in this audience are well aware, the DoD system is under a microscope nationally and has been featured in each of these major news outlets. So our aim was to determine differences in 30-day outcomes for major oncological resections between the Department of Defense and civilian hospitals using the National Surgical Quality Improvement Program, or NSQIP, database. We looked at 4 major index operations over a 10-year period, specifically evaluating for 30-day overall mortality and 30-day postoperative occurrences or postoperative complications for colectomies, pancreatectomies, liver, and esophageal resections. We compared DoD to the civilian hospitals for total case number, demographics, total 30-day mortality, as well as mortality broken down by procedure, and the quantitative and qualitative post-operative occurrences using descriptive and comparative statistical analysis. For our results, we found that there were no differences between the two types of facilities for age, race, or gender. Their preoperative health status was also no different as defined by number of preoperative risk factors, average BMI, the rates of diabetes mellitus in the two populations, and overall functional health status. When looking at the total cases, we were able to compare 1,338 to over 260,000 in the civilian cases. We found that they had equivalent rates of postoperative occurrences or postoperative complications between the two groups, with approximately 1/3 of patients requiring some intervention for a postoperative complication. However, these were no different between the two groups. In terms of overall 30-day mortality, these were also equivalent and not statistically different between the two groups, with actually a slightly less rate at 8.8% in DoD facilities. When we broke these down by procedure, we also found that there was no difference between the two groups for colectomies, pancreatectomies, hepatectomies, and esophagectomies. Interestingly enough, the DoD had no deaths recorded over that 10-year period for patients who underwent esophageal resections. When we looked at the individual patients' postoperative complications per patient, we found that the vast majority had only one complication within the 30 days after their operation. When we looked at the mean number of occurrences, we actually found that the DoD had slightly lower number at 1.7 per patient versus the civilian at 1.8. In terms of the quality of the postoperative, or our qualitative data of the postoperative occurrences, we found that there were significantly higher readmission rates for DoD facilities as well as unplanned reoperations. However, when looking at urinary tract infection, postoperative sepsis, and deep venous thrombosis, we found that there were no difference. This was also true for pneumonia and pulmonary embolism. And in fact, if you had your operation done at a civilian center, you were actually more likely to undergo an unplanned intubation. So from this data, we can say that military facilities' outcomes are actually comparable to their civilian counterparts. We actually found overall less mortality over a 30-day period, whereas pancreatectomy and hepatectomy had slightly larger rates of mortality. However, none of these numbers were statistically significant. In terms of morbidity, we found similar rates of post-operative complications with higher rates of readmission in unplanned operations in DoD facilities, but higher rates of unplanned intubations at civilian hospitals. This suggests that military hospitals probably can meet the standards nationally despite our lower case volumes. So how might we explain these results? Well, we have found studies that have several characteristics that are associated with better outcomes in low volume centers. These include centers that have high nurse ratios, medical oncology services, bariatric surgery services, PET scanners, institutions that are associated with teaching hospitals, those that have full-time ICU staffing, and those who have general surgery residencies. Luckily, most military facilities have all of these things, or at least most. With regards to the actual surgeon skill, when a highly experienced surgeon operates in lower volume hospitals, outcomes are preserved, suggesting that the outcomes are likely due to the surgeon's skill and not the institution at which they are practicing. There are many important limitations we should discuss. First, this is a NISQIP database study, and therefore we are limited by the abstraction of data from that collection of work. The majority of our data actually came from colectomies, which potentially could have skewed our results. And there was a relative heterogeneity in the operative indications for our major index operations. And finally, we weren't able to stratify based on this database for the different volumes of different volume hospitals in the civilian sector. But the big question is, given this data, where do we go from here? So despite the favorable data that I've shared, the general feeling that low volume centers equals higher mortality is likely not going to change. And there's already a trend nationally to centralize this care in the hopes that we will provide our patients with the best possible care. For us in military facilities, we have really two options and one imperative requisite. The first option I submit would be to increase our caseloads by somehow recapturing those patients that we have outsourced to other institutions. Conversely, we can also outsource ourselves and make partnerships with neighboring institutions so that we can get these case volume that we need to be able to have the experience that our surgeons need. And finally, and probably most importantly, we need to keep high-quality, evidence-based care at the forefront at all of our military hospitals so that we can maintain and then continue to improve on the data we've shared today. Thank you, and I'd be happy to take any questions.
Again, we're open for questions at this time. I'll be honest with you, I've been waiting all morning for this particular presentation, so.
Yeah, I have a quick question. You know, when we talk about the concept of low volume, high volume centers, I know you looked at the morbidity, mortality, and kind of some broad strokes and several metrics that you can look from NISQIP. But when you do evaluate like cancer patients and operations, are you also looking at oncologic outcomes?
That's a great question, and I think an important one, sort of alluded to in my limitations. We didn't, and that would be something that we would love to do in the future. And I think it's a great point that your outcomes are going to be, as far as what matters to the patient, that the oncological outcomes are probably going to be paramount, as most patients aren't going to die from their operation. Because
I would think that the one thing you could look at, given that limitation, is like in those operations, how many of those patients had R0 resections versus suboptimal resections.
Right. And I think it's a great suggestion, and we'll go back and look at that.
Also, nice presentation. Did you guys look at what percentage of your cases were in each category, as in, did your subsets for each category compare similarly to the civilian counterpart?
Yeah, so the quick answer is I don't know. I know that we had the higher rates of colectomy. That made up the majority of our data. I believe it was around 65 to 70%. What that compares to nationally, I don't know. I'd have to go look at those numbers.
Thank you. So this was a fairly hot topic for those who attended the AMSIS meeting, and all services were there. Navy, Army, Air Force, and the DHA was there. And again, My only concern is there are a lot of articles that are coming out, not only just from the military, but rural centers who I feel are trying to defend the fact that they are low volumes, and we're trying to fight this resistance of, these high volume centers. I think that though, it was when you look at that data, you really have to look at those specifics based upon those last two questions to truly say if you can make that statement that low volume is okay. I wholeheartedly agree with you. I think in the military we do have that luxury of having better care because we do have a higher volume of healthcare providers to patients. But then when you look at those other centers, they are a machine basically. They see lots of patients and they see lots of volume. But I think that's some of the discrepancy when we're looking at the study here. So
Yeah. Thank you, sir.
Thank you very much.